Welcome to this webinar, Connecting Sustainable Farmers to Emerging Healthcare Markets, a farmer-focused presentation. I'm Anna Clausen. I've been the project coordinator for this 2-year project, and will have the pleasure to help moderate this webinar as well as give some of the presentation. Let's begin. A quick overview of what today's webinar is going to look like. As I mentioned, I'll give a project overview, and our primary consultant will go through our project findings. A few things to note before we go through this. We'll have some of our advisory committee members give a presentation about their personal story in buying and selling into the healthcare market. And we'll have some time at the end for questions and answers. There are 3 things, technical issues, that I'd like to let you know. At any time, you can switch from your computer microphone speaker setup to call in. The information for phoning in is in the audio panel of your GoToWebinar, and you can select the telephone button and the information will appear. Second, the webinar will be recorded and available at IATP.org and at IATP's YouTube page after the webinar concludes. The third thing is that you can ask questions during the webinar. To do this, you'll want to use the questions dialog bar to enter your questions into the dialog box. Please feel free to put them in as they come up, and we will do our best to get them answered either at the end or if there's some time throughout the presentation. So let's begin. IATP is an organization that works at the intersection of policy and practice to ensure fair and sustainable food, farm, and trade systems that create healthy food and ecosystems. As an organization who works on creating healthy food and ecosystems, it would seem a natural fit to focus on farm-to-hospital, as well as farm-to-school and farm-to-preschool. After all, farm-to-preschool promotes children's health and their food literacy by familiarizing them with good foods early. It's the building blocks. And farm-to-hospital, where hospitals play are the role models for healthy living, is really where we start and put our focus on what we put into our bodies in the form of nutrients. However, it's critically important, as these reasons are to IATP. IATP's role in farm-to-institution is also very much focused on the role it plays in strengthening local economies by expanding markets for small and mid-sized agricultural producers and food entrepreneurs. To help build stronger local food systems that work for farmers in the community, we're going to need institutions with significant purchasing power to step up. Hospitals and schools are already serving local communities, can be an important first step to building a healthier, more sustainable, and resilient food system. For IATP, one core area of our work focuses on the building of a decentralized and democratized food system that is just and healthy. We must transform laws, policies, and markets to help these systems grow and thrive. And for this work, IATP has identified a number of targets. One of them, a prime focus, is on shifting procurement policies. And that's why we're here today to talk about this project. As public procurement policies are a lever for creating a market for a more decentralized food system, over the last 5 years, IATP has been working on just that, and been working specifically on expanding farm-to-school programs. This effort has included work with schools to market programs, identify farmer needs, research opportunities for season extension, as well as healthier food production. And we've developed a curriculum for students to actively engage in these programs. We're also developing farm-to-child care programs related with educational materials for kids and parents. And we've been working, as this project suggests, with hospitals and farmers interested in developing new procurement standards that incorporate health and sustainability. So while hospitals can be lumped into this larger discussion about farm-to-institutional purchasing, it's also really important to note that there are some unique opportunities and challenges when it comes to farm-to-hospital related and compared to farm-to-school or farm-to-university or other farm-to-institution models. Some of these will be talked about in Marie's presentation, what you see here on the screen. I'm not going to go in depth, but I do want to note 2 opportunities that I think are often overlooked. One of them is that hospitals are on the front of resiliency. Hospitals, like other businesses, are looking to mitigate their risks to threats outside of their control. But they're especially attuned to these large epidemics, like food pandemics and oil embargoes. And they're extremely vulnerable as they house the most vulnerable. So developing a more local system is the key to this resiliency. On the flip side, hospitals face some unique challenges, some of which I've mentioned here, that really rely around this variability and wide breadth of difference in ownership, management, and different types of supply chain partners. But the fourth I want to mention is that there's a challenge with churn in staff and policy. Yes, this exists in other institutions, but especially as hospitals are stepping into this new realm of doing more local purchasing, it's important to note that a lot of times these things are championed by individuals, and there's a need to make that effort institutionalized so that when there's staff turnover, that all of that progress is not lost. So let's get into the project. The project intent and outcomes. This is a project that's a 2-year project that was funded by SARE as a research grant. And SARE is the North Central region of this project, which SARE is the Sustainable Agricultural Research and Education Program, which is a nationwide grant and education program that advances sustainable innovation to American agriculture. So a part of this 2-year research project was to really assess the potential market and the current market for farmers and producers within the SARE region, which will outline the 12 states that are the North Central United States portion of SARE, one of their 4 regional offices. And through that process, there were some outcomes, and we developed some tailored roadmaps for our hospitals that participated and outreach materials for farmers. Project goals. In essence, and if I can refine this down, one of the main goals was really to demystify the healthcare market for farmers and producers, and to get a better feel for the actual market. Now, in the near term, this starts with just increasing knowledge, and to the long term, we really hope to build a market that's significant in size and straightforward for farmers to access. The process. The process was really enjoying. I think one of the things to highlight about this project was what happens throughout the process of a research project. It ends up being, in many cases, more than research. On the research front, we did do a lot of analyzing of food and beverage purchasing data from our 3 participating hospitals and healthcare systems. And we conducted a number of surveys with regional farmers to get a feel for the supply and demand and the issues that they feel are the biggest barriers to getting into this healthcare market. We also convened an advisory committee, which was crucially important to being able to test ideas and have open discussions between hospital staff and local farmers. Making up our advisory committee and putting forth a big commitment to this project were 3 healthcare facilities: the St. Cloud VA Medical Center, with assistance and help from Angela Gross and Kristen Huselid. The second was Hudson Hospitals and Clinics, with Jennifer Condi and Jean Weiler as the Supervisor of Nutrition and Nutrition Manager. And Fairview Health Services. Currently sitting on the committee is Sabrina Bong and Wesley Waters, who are the Senior Wellness Specialists and the Sustainability Coordinators for Fairview Health Services. What's important to note is the diversity we were able to capture within our advisory committee. It's great. We'll talk through some of these challenges and differences, but just with 3 healthcare systems, we were able to cover the perspective from different ownership levels, a government-owned facility, nonprofit, independent community facilities, as well as a lot of different levels of involvement in currently buying from local producers. Also on our advisory committee were our farmer members. Our farmer members consisted from the same region, really reaching out to the west, as far west as St. Cloud, a little bit further west, and into Wisconsin and western Wisconsin and down south of the Twin Cities metro area. We're grateful to Wilson, Jody, Christina, Sean, John, and Gary, who represented their farms and their families on this committee. In addition, Teresa Engel and Collie Graddick brought us the perspective of both the Minnesota and Wisconsin state agencies, as Teresa sits on the the Wisconsin Department of Agriculture, and Collie representing the Minnesota Department of Agriculture as a consultant, and also as an active member in a co-op of local producers in the Twin Cities. The thing to mention here is that you see that we had an active committee of just a handful of producers, but they had a broad breadth and depth of experience. Some of our producers have sold to hospitals, others have never sold to hospitals or institutions. Some are just interested. Some have sold and are no longer selling. And so they all brought that perspective from the products they produce within our committee. We cover vegetables, herbs, fruits, bison, beef, dairy production, turkeys, chickens, eggs, pork producers, as well as even some value-added ciders and pies, just from these 6 producers. And also their years of experience. We have this variable years of experience and ownership, from women-owned to co-op-owned, veteran and minority-owned farms. So as I conclude, that is an overview of how our process went. There's a lot of project findings, so I'm not going to stick too much on what we did over the 2 years. At this point, I would like to introduce Marie Kulik, who is our consultant for this project. Marie actually has history with the Institute for Agriculture and Trade Policy, and she used to work for us prior even to my time here at IATP, but has been a consultant on this project for the last 2 years. And Marie really brings years of experience helping hospitals and health systems adapt and revise their purchasing guidelines and food sourcing contracts, including written policy language and contracts. And Marie really is one of the only people, if not the only person, that we feel has the knowledge, expertise, and frame of reference to implement a hospital procurement project on a systems level. So I'll hand it over to Marie, our principal investigator on this project, to go over the key project findings.
So hello, can everyone hear me? Oh, I guess I'm going to assume that you can hear me, and you'll let me know otherwise, because I guess everyone's on mute. So to start with, and thank you, Anna, you did a really great introduction to the project, very thorough as always. I would like to begin by talking to you about how we defined what a sustainable farmer and producer is for the purposes of this project, because I'm sure as all of you know that there is no one uniform definition that's used. So we ended up using there we go, okay. The Green Guide for Healthcare, which is a voluntary benchmarking system that was developed within the last 10 years for hospitals and health systems to use to determine, where their baseline was in terms of having sustainable design and operations, including their food service operations, and what were some of the steps that they could take to improve on the sustainability of their operations. And as part of the Green Guide for Healthcare, there's a whole section that is devoted to greening food service operations. And so our definition for this project of a sustainable farmer and producer, we looked at what's called the Food Service Credit 3, the Local Sustainable Produced Food Purchasing Credit. And the credit is designed for hospitals to use to benchmark their progress and to be meaningful and enable them to be able to count things. So in the context of what a sustainable farmer and producer is, it would be someone who is producing food items that are, one, either approved to carry a third-party certification, and specific certifications are listed that are considered meaningful, developed independently, et cetera. And so I've listed a few here that everyone is probably aware of: Certified Organic, Food Alliance Certified, which is another somewhat national certification. Then the next thing would be producers that are growing or selling products that carry one or more USDA or FDA allowed label claims, such as raised without antibiotics or raised without added hormones and hormones added. And as part of this, we also try to educate hospitals about which products those labels are applicable to. And then the third piece is basically a farmer or producer who is located within 200 miles of a facility and is using sustainable methods. Usually they're smaller scale, mid-scale farms that aren't necessarily packaging their products for a commercial market and or have not gone to the added expense of becoming third-party certified. So that's the definition we use, and it was used when we did the baseline for the hospitals, but just so you have an idea of, generally speaking, when we're referring to sustainable farmer and producer and the kinds of farmers we're working to connect to hospitals, that's what it is. So, and also I know that Anna mentioned that the grant came through the North Central Region Office of SARE, and so most of the products that we created as part of this and the data that we gathered is within the context of North Central region states and helping those farmers in those states and hospitals in those states to connect. However, if you're a farmer that's from another state, much of the information that we share here will still be applicable to you. It's that not every single tool that we created is going to be useful to you. So when we're talking about what the healthcare market is for sustainable food, the first thing I think we should look at is, so what's the number of potential customers? And across the United States, there are nearly 6,000 hospitals. In the North Central region, we have closer to 1,500 community hospitals, and those are hospitals that are not federal hospitals or other specialty hospitals, some psychiatric hospitals, maybe a hospital that is in a jail or something like that wouldn't be counted as a community hospital. And they also are things like, the children's hospitals in your community, the heart hospital in your community, the county hospital in your community. Those would all fall within the definition of a community hospital. And then in addition to that, even though there are more federal probably medical facilities, so that we didn't count in this, there are 37 VA hospitals and medical centers, and we specifically recruited a hospital that is a VA hospital to be part of this project so we could take a closer look at this market for farmers. And there are also military bases in your states that probably have a medical facility on site that serves food. These are going to be more public facilities, probably easier for you to gain access to. But anyway, so that is what we were talking about in terms of raw numbers of hospitals. In near term versus long term, that every one of these hospitals over the long term should be considered a potential customer. In the near term, there are some limits that are going to end up dropping some numbers off of this list, and we'll talk about that in a little bit. If you are interested in determining, what hospitals are close to you within your state or within a certain number of miles, we have a resource and I'll later show you the link at the Farm-to-Hospital website or page on IATP's website that has, we've listed every hospital association in the region and then some more general links that hospitals anywhere can use to search for hospitals in their area. There's lots of other information as well in that document just to show you that. So, so now in turning from the numbers of hospitals to what is the market value? How much are they actually spending each year on food and beverages? We first started by looking at the procurement data that our hospital collaborators were willing to share with us. And before I show you these numbers, I want to show that our project collaborators included 8 facilities, varying in sizes, some as small as 25 beds and others with more than 500 beds. Combined, it was nearly 2,000 what are referred to as staffed beds, and they have many thousands of employees, and combined they serve approximately 3 million meals a year to patients, staff, and visitors. And the asterisk means that though the veterans facility in St. Cloud participated in our project, it was the patient side folks that participated. The VA St. Cloud, like many VA hospitals, outsources their retail area management of food service to Veterans Canteen Service, and I think I said that right. But so they did not participate in the project. So these numbers are slightly less than they would be if we included the retail side of the VA. So anyway, so just our project collaborators in 2012 spent together approximately $6.6 million on their food and beverages. And that number doesn't include money that they spend on if they have to feed a patient intravenously, what's called an enteral feeding project. This is just raw ingredients for food or prepackaged food items that they then would serve or sell to hospitals and patients. And just you can see here, just to give you an idea of the breakdown, the largest portion of what they're buying is spent on grocery items, and most of the items in that category are things that are not grown on farm in the United States. They're prepackaged food items and you know, frozen bakery items that all they have to do is pop in the oven, or and also things like spices. There are some things in there that, you know, we have producers here in Minnesota and Wisconsin that, you know, if they do buy some flour and you know, grains and things like maple syrup and honey would come under the grocery category, but they're a very small portion of this. But you can see that the rest of what they spend is largely, other than maybe beverages, non-dairy beverages, what things that are produced on a farm, or, you know, by a rancher or a beekeeper or something like that. So that's a big chunk. Most of what they are buying fits into that category. So, and then just to give you an idea of the volumes purchased, this is just 1 year by all of those 8 facilities, not including the VA retail area. 800,000 pounds of fresh produce, nearly 500,000 pounds of fresh frozen beef, pork, and poultry, 64,000 pounds of cheese, lots of yogurt, lots of cottage cheese, butter, cream cheese, etc. 104,000 pounds of liquid eggs. I'm sure many of you know that they buy a lot of pasteurized liquid eggs, but they do also buy shell eggs, and so there's a considerable amount of shell eggs that were purchased, and 91,000 gallons of fluid milk. So if you want to know more detail about what our healthcare collaborators purchased, we have put all of that aggregated data into an appendix in the report, which you can download from the website. So when we take that data and we extrapolated it, which is a little complicated because hospitals vary considerably in how much they actually spend on food. And you know, it's going to depend on food costs, where they are, who their supply chain partners are, how many people they're actually feeding on a daily basis in terms of patients, how many staff or visitors eat in their retail cafes, how much catering they do on site. All of those things have an impact, and they don't typically report those numbers in any uniform fashion where we could just pull that data up. So to do an extrapolation, we had to compare how much was spent by hospitals that fit into a certain size category. So you know, a hospital that has 25 beds or less, or a hospital that has between 50 and 100 beds, and so forth. And so these numbers are really pretty ballpark. They just give you a somewhat educated idea of what the market is. And the conservative end is the $689 million, and to up to $1.3 billion, and that's just the community hospitals in the North Central region. So I didn't look at it. Probably would have been interesting to look at what that market is compared to, you know, elementary schools from some of the other farm to institution work that's doing, but I didn't look at that. But then we also looked at the VA hospitals, and just the 37 VA hospitals in the North Central region are spending nearly $30 million, and that's actually based on fiscal year 2010 numbers, and given cost increases in food dollars and so forth, the market is probably more than that. So once again, that's a pretty conservative number. So I already talked about, I guess, what some of the influences are: food cost, meals served, types of products that they serve, that are all going to have an impact on how much they actually spend on food. And we already looked at sort of the rough breakdown. And I would imagine from the slide that I showed you earlier that many hospitals across the country are going to have similar breakdown between what they spend on grocery and what they spend on meat, etc. The percentages might vary a little bit from place to place, but so, and then I just want to talk a little bit more about what some of the market variations are. There's a difference between the largest markets, basically the states that have the greatest number of hospitals and the most beds are Illinois, Michigan, and Ohio. And the smallest in terms of dollars spent, fewest number of hospitals, fewer beds, is the North and South Dakota. Like I said, among our healthcare collaborators, we had some very small hospitals represented, and we had some really big hospitals represented, and that's pretty much the way it is throughout the region. we have so 61% of hospitals in the North Central region have 99 or fewer staff beds. So they're pretty small, a lot of the hospitals, and that in terms of the numbers of patients that they're serving every day, and actually the number of people that they serve is less than staffed beds, because that just represents what they would be capable of, on a daily basis, whereas what you really would want is the average daily census, and those numbers are really hard to find, but they are generally a good bit, 10 to 25% or more less than their staff beds. So I just want you to come away with this with the idea that much of this market is, they're the small hospitals, the smaller hospitals. So you don't have to necessarily be producing a huge quantity of something to be able to sell to a hospital. They tend to spend $140,000 to $400,000 a year on food, whereas the big hospitals are going to be spending, $1 to $5 million on food a year. And then the other thing that's important in terms of market variation is urban versus rural. Most of the VA hospitals are in urban areas. I think maybe roughly 25% are in what are considered more rural areas. And it's roughly split. I think there's slightly more North Central Region community hospitals that are in rural areas than urban. But that also varies from state to state as well. So, some hospitals have, I might have a slide on that. I just want to say, if you want more data, before I leave this slide, on the Procurement Data Act extrapolations and how we did them, there's an appendix in the report that contains that data. So here, I was talking about rural versus urban. So approximately all of rural hospitals have 25 or fewer staff beds. So if slightly over half of the hospitals in the region are rural hospitals, what we're saying is half of those hospitals then have 25 or fewer staff beds. Urban hospitals tend to have 100 or more staff beds. And this doesn't mean that urban hospitals are not going to be small. You will still find some smaller hospitals within urban areas, especially specialty hospitals like a Shriners Hospital for Children or something like that might be a much smaller hospital, or a specialty hospital. But you can see here, just by looking at this slide, I put them in order that, Nebraska, North Dakota, and South Dakota, the greatest portion of their hospitals are in rural areas, whereas Ohio, Indiana, Illinois, Michigan, much more of their hospitals are in urban areas. So just to give you an idea of what the difference would be in a demand between a small rural hospital and a large urban hospital, we have this chart here, and in the purple color is the rural column, and it's a hospital that would have 25 staff beds, average daily census of 15, 300 employees compared to, say, 6,000 employees at an urban hospital. And if you just look, I just have a few samples of what the rural hospital might be spending in volume. We already talked about the differences in the market value, but in volumes. So, for instance, in bold, I have that a rural hospital might have 900 pounds of turkey that they buy every year in varying forms. So, it might be breast, it might be legs, thighs, etc. And an urban hospital is, close to 15,000 pounds. So there's a big difference in terms of volume. And even for the small hospitals, you wouldn't necessarily need to provide all of that volume. You could be looking at replacing a portion of that volume, or a specific product type, or a specific product for a certain period of time. So there's lots of ways to look at this. This is just to give you a snapshot. And so Anna, I know you wanted to pause here. Are there any questions before I move on to the next section?
Hi, Marie. This is Anna. I don't see any specific questions, but it's a good reminder because there'll be more and more information that's very number specific. If you have some, I will try to filter them throughout this presentation, so please leave them in the question chat box. So you can go ahead, Marie.
So, all right. Okay, great. So there are a lot of factors that influence this market, and I'm sure you're going to think of some as we're going along that we're not listing here. We're trying to stay focused on, what we think are the key factors. And we'll go through these in more detail in a minute, but this is what we're going to cover. So sort of what is the hospital interest, and how they're, what policies do they have that might influence this market, staff interest, it's food service staff interested in particular, existing supply chain relationships and how they influence the market, food service management, and confidence and trust. And there is, cost is also a big issue, and I think we'll cover that a bit under existing supply chain relationships. Of course, hospitals are very focused on keeping their costs low. And I don't know why, but my screen just froze. There we go. Never mind. So just to give you an idea, the Food Service Director magazine is a trade magazine that lots of food service, not just hospitals, read. And every couple of years they do a hospital census, and they typically, in the last, I'd say, 8 years or so, have been asking hospitals questions about whether or not they purchase organic and locally produced food. And it's not a scientific survey in the least, and all you have to do is look at that little chart to the right to understand why. But so basically, their 2012 census demonstrated that all hospitals said they were purchasing at least some items locally, and between 19 and 56% reported that they were purchasing organic items. Folks on the West Coast were the 56%. 19% was actually East Coast, and the central part of the country was closer to 33%. But if you look at the chart on the right, this relates to the local items that they're purchasing. Dairy and produce are very much at the top, but they also list things like baked goods, which they're probably buying from a local bakery based on, my understanding of how hospitals do their purchasing. And under meat and seafood, it's entirely possible that they're counting things like Hormel, if Hormel is located in their area. And of course, coffee, 16%. We all know coffee is not produced in the United States, so purchasing it locally doesn't mean that it's coming from a local sustainable farmer. But it's on their radar, so I guess that's why that's sort of there, and the certified organic is pretty specific. So there's some work going on there. The other thing that indicates probably a greater level of interest on the part of at least a subset of hospitals is that approximately 9% of the community hospitals in the North Central region have signed something called the Healthy Food and Healthcare Pledge, and or are participants in something called the Healthier Hospitals Initiative Healthier Food Challenge, which includes trying to meet certain percentages of procuring food from local sustainable farmers. When we looked at the market, these hospitals, this 9%, as a subset of the broader community hospital market, just those hospitals spent between $75 and $220 million on food in 2012. So just looking at those hospitals that have expressed formally some kind of interest in this, they're a significant market just in and of themselves. So, and just to show you in terms of, there aren't generally percentage-based commitments for having signed the Healthy Food and Healthcare Pledge. And again, just in that one document I mentioned, the online resources, we have links that you can follow to get lists of the hospitals that have signed the pledge and have done this challenge, and download this report if you want, and so forth. But we looked at, what progress have they made, and this past spring, the Healthy Food and Healthcare Program and Healthcare Without Harm put together this menu of change report, and they did a periodic survey of hospitals, and among the hospitals from the North Central region that responded to the questions related to this, they were buying about 10% on average of their total food budgets, was being spent on sustainably produced food, and then separately reported 19% was being spent on locally produced food. So, and there's some overlap there. You could see the range was somewhere between 8 and 38% of their budgets was being spent on those. So they've made some progress. Some hospitals have made some progress after they've been focusing on this for a while. And then if you look more nationally at the broader numbers that are reported in the report, they're slightly higher. 21% for sustainably produced and 23% for locally produced. And then there are some leading hospitals that have done, in some cases, more than double those percentages. Like Fletcher Allen Healthcare in Vermont has won the Sustainable Procurement Award 2 years in a row, and they've been working on it for like 10 years. So among our project healthcare collaborators, one of which was just getting started, and the other two hadn't really been focused on this. Without much effort at all, we're averaging 4.7%, and most of that, and there was a range between roughly 2 and 9%. Most of that was to buy milk that was produced without recombinant bovine growth hormone, but there was a certain amount of local produce that was purchased as well, and some organic grocery items. Before I leave the subject of hospital interests, I also want to mention that though, it's somewhat voluntary, the VA, Veterans Health Administration, has adopted what they refer to as their healthy diet guidelines. This was back in 2010, and though they are largely focused on improving the nutritional quality and getting more fresh items onto the plates of veterans at their facilities, there's a piece of this that encourages these hospitals to be purchasing more seasonal produce from local farmers, sourcing milk produced without hormones, and meat and poultry raised without antibiotics, etc. I know that there are some hospitals that have made real progress in this area within the VA, but largely I think the other ones are just trying to figure out how to get going on it within the constraints of their system. But this just to show you that there is an awareness and a push for incorporating more of these types of products into their food service operations. So the next area of interest is looking at hospital employee interest, and just quickly want to touch on we did a survey of all the food service staff that work for our healthcare collaborators, and some interesting data came up, and again I'll show you in a second what document we put most of it in, but what it demonstrated was that the food service employees have a strong interest in their hospital purchasing and serving sustainably produced food. 70% believe that it's in line with the mission of their hospital, and almost all of them were willing to pay at least something more to have food items available to them that were sustainably produced over conventional ingredients. So hopefully that's clear. Oh, here we go. So maybe, what was that? Oh, I'm sorry, this other one was that they were likely to choose food items and meals that were made with sustainable ingredients over conventional. And this slide now is about how much they're willing to pay for a lunch made with sustainable ingredients. So we gave them an example of a typical $5 lunch, and 69% of them said they would pay at least 10% more if it was made with sustainably, produced ingredients, including those from local farms, and 14% said at least 25%, and there were some that said, even more than that. You could see there was some percentage that was willing to pay more than 30% more. So, and many of them believe that the hospital should feature foods made with sustainable ingredients on a daily or weekly basis. So, not just on special occasions. So the third major factor that influences this market is existing supply chain relationships. And hospitals have both formal and informal commitments to purchase their food through certain suppliers. And usually the percentage I hear most often is around 80%. But interestingly, none of our healthcare collaborators actually had a contract that specified a percentage. Instead, some were just encouraged, the more they utilize the contracted or the prime vendor, the better pricing they would get. And if some of the hospitals reached a specific percentage, like 85% threshold, then they would get a bigger discount. But even if there isn't a contractual commitment, there's usually a lot of pressure to utilize the prime vendor contract as much as possible to keep costs down and maximize the amount of reductions they can get from the various volume discounts. Among our project collaborators, what we discovered was that almost 90% of what they were buying came through their prime vendor, their mainline distributor, so like a US Foods or a Cisco, in some cases maybe a Reinhardt, and then much smaller percentages were being purchased through a regional or specialty distributor like a produce distributor, or getting some of their milk from a dairy supplier or a bread supplier. And at this point in time, very little of it was coming directly from farmers. There was at least one hospital collaborator that was buying directly from farmers. And there's flexibility that's built into this. They're not buying 100% of what they're getting through their prime vendor. The flexibility is typically around purchasing fresh bread and milk and produce from sources other than their prime vendors. And that, specifically built into the VA contract, they're encouraged to go elsewhere for those fresh items. Just so so these are just some of the key factors I think I've already mentioned in terms of their existing supply chain relationships that, in some cases, there are contracts, there are both real and perceived cost savings in making full utilization of these contracts. The other thing that I want to put out is that for these other distributors, like for the VA, they do have a contract with their bread supplier and their dairy supplier, but the other health systems just had relationships with these suppliers. They didn't have a specific contract. They were just ordering from them. And so, that's sort of business of usual, ease of ordering and so forth. And I mentioned the internal pressure. So if any of you have ever tried to sell to an institution that has contracted out their food service to a food service management company, you know that this can be a major factor in determining whether or not you're going to be able to sell to any institution, and that includes hospitals. So who uses or who contracts out their food service contractors? Reports really vary. Once again, there's no one place where you can look and find this data. It seems to be somewhere between 17 and 20% of hospitals nationally who contract out their food service, and so that means a lot of hospitals are managing their food service in-house. But it really also will vary from one place to another. So for instance, here in the Twin Cities Metro, a lot of our hospitals in the metro area are using one of the 3 major food service contractors. Also, food service contractors may manage, all operations at a hospital or just a portion. So, and when it's just a portion, it is usually that they're managing the retail side and not the patient side. That may not always be the case, but that is typically how that works if they're splitting it. Of course, many of you may be familiar with the names of the top 3 in terms of overall revenue. Compass Group and their Morrison division is the one that does most of the healthcare contracts. And then Sodexo and Aramark, and I believe that at least 2 of these, if not all 3, are multinational corporations. And they do, of the hospitals that have food service contractors managing their food service, most of them have one of these 3. But there are other companies that do food service management. And for instance, I already mentioned Veterans Canteen Service manages the retail operations for most of the regional VA hospitals. And but there are some others that I'll show you in a minute. And so some of the key factors that are related to food service contractors is that some, not all, but some may prohibit their staff from buying directly from farmers and producers. They may require producers to go through a vendor approval process. The requirements can be, particularly onerous and prohibitive for smaller mid-scale farmers that can't meet their insurance requirements or their good agricultural practices, certification requirements, etc. They also have their own supplier loyalty programs and relationships, especially the large ones. I'm not sure about the smaller ones, the more regional ones. But in some cases, the contract they have with the hospital could require them to use the hospital suppliers and then they wouldn't be able to use their own. So it really varies there. There is something called the Healthy Food and Healthcare Contractor Pledge, and the companies that are listed here have signed it, have basically pledged to help the hospitals that are, there are accounts that are working to implement parts of the Healthy Food and Healthcare Pledge at the hospital level, and then there's some corporate related criteria. And so you can see on here there are some names that food service contractors that you may be less familiar with that are more regional. So Fresh and Natural Food Service Group, I believe, operates out in California. HHA Services, I think there was maybe in Michigan. So some of these, Unidyne Corporation does a lot in the Northeast. So it's coming away from that. Actually, the door isn't necessarily blocked if they have a contracted food service in all cases, but it is if they do have it, depending on who they have, it's a definite short-term barrier for you while that hospital still works with that contractor, unless the hospital goes around them and purchases directly from the farmer, which we've heard about, but we didn't find a lot of examples of that to talk about in this project, so we don't here. So getting towards the latter part of the, and I think I'm getting close to running out of my time, but confidence and trust is a big deal in terms of a key factor. Hospitals, because they're dealing with vulnerable populations, really need to feel confident that what they're serving patients isn't going to lead to further illness. And a lot of them do sort of voluntarily follow HACCP for food service operators, and so that sort of relates to their purchasing in regards to them buying from quote-unquote approved sources. And an approved source is really nothing more than, you know, what you basically have to show that you could meet whatever the local and state and federal requirements are. So if you're a producer in Wisconsin who wants to sell to a hospital in Minnesota, you've got to be able to demonstrate that your food was processed in a USDA inspected facilities because you're selling across state lines. So sort of that kind of thing. So, and then unfortunately some and maybe many believe that it can be risky to purchase food from sources other than their previously vetted suppliers. And I think this sort of, some hospitals really don't even think about that. But others are consistently turning to that as a reason for why they can't buy directly from farmers. And so some of this has to do with a lack of experience or having had a prior bad experience. More often than not, I think it has to do with supplier scare tactics, and that the big distributors really sort of try to emphasize their food safety programs as being what's necessary to assure that whatever's coming in their door is safe for them for their patients and staff to eat. So there's definitely a need for more education there. And then some other influencing factors. Obviously, I already mentioned that a lot of their supplier relationship are related to keeping costs down. And so when we did the survey, you know, clearly our survey results showed that the patient and cafeteria meal planners, most of them believe that they would need a budget increase to incorporate more sustainable ingredients into patient meals. And 61% thought that they would need additional staff to be able to prepare more meals that are fresh and whole ingredients. So there's a perception that most of what they buy is going to require extra work to put on the plates than what they're getting from their distributor. And that's not always the case. So I don't think I've showed you this before, but again, one of the appendices provides very detailed aggregated information on the Collaborator food service survey results. And I think all these documents I'm pointing out to you because I think that they would be really helpful for you to read, to understand the market, and think through, you know, what your approach might be going forward. And Anna already mentioned this last influencing factor, and that the commitment level that happens at the staff level, so if you've got a great relationship with a food service person, it doesn't always make it up to the upper level, and even if it does, there isn't always an understanding of what can happen if 1 minute you've got, you've been working with 5 farmers for, the last 5 years, and then upper level management decides that they're no longer going to be doing food service in-house, they're going to contract it out. Overnight, that can have an influence on, what they're buying and from who. And so, keep that in mind, and as you're communicating and building your relationships with hospitals. It's not always going to happen, but that their possibility is there until this becomes more of a, this is the certain percentage we're always going to be buying directly from farmers, and we're not going to do anything that's going to have a negative impact on that relationship. So just to quickly review the key lessons learned. So, we believe there is a potential healthcare market for sustainable foods. Many hospitals and their staff are interested in buying at least some portion of their foods from sustainable farmers and producers, both more broadly as well as in their communities. And most hospitals have at least some flexibility to purchase food from sources other than their existing suppliers. Of course, again, if it's a contractor who wants them buy direct, that is somewhat limited. But anyway, so most hospitals, but especially smaller hospitals and rural hospitals, manage their food service in-house. And all hospital food service staff need to be confident that what they purchase isn't going to lead to further illness. So those are some of the basic truths coming out of this. In the near term, there's more opportunities for farmers that are selling, sustainable farmers in the region that are selling to the Cisco's and the regional produce suppliers and have their product available through the supply chain that hospitals are already using. And in that case, they just need to make sure that they do whatever they can to maximize awareness among the customers of those suppliers that they can purchase that farm or farm collaboratives products through the distributor that they have, because you can't rely on the distributors to make that information available. But in terms of connecting to individual hospitals, the greatest near-term opportunities are going to be with smaller hospitals, rural hospitals, and hospitals that manage food service in-house. It doesn't mean you're not going to be able to sell to some of the other ones, especially if you're maybe a bigger farm, but we would really encourage you to look at this to plan out your approach to the market. To help you further understand how healthcare purchasing works, it created a primer that, again, is going to be probably interesting for farmers anywhere in the country to read. We do have some North Central region specific statistics in here. And back to this connecting to individual hospitals, I would encourage you to, start with one and build a relationship with that one hospital, make it a good relationship, and, learn lots of lessons and then figure out from there how to go beyond that. We encourage you to be proactive about addressing potential food safety concerns. I know a lot of farmers get upset when there's an implication that your food isn't safe. But if you want to sell into this market, you have to have some kind of at least a basic recognition that that you need to be proactive. And so I would say things like, make sure you understand what the local, state, and federal rules and regulations are. So if you're meeting with a hospital purchaser, you know what you're required to do and what you're not required to do. And you also know if you're going beyond what's required so that you can tell them. We encourage you to go beyond regulatory requirements that as feasible to help increase confidence. And so, develop an on-farm food safety plan if you can. If you're selling produce or want to sell produce to a hospital, at least complete the USDA Good Agricultural Practices Training Program and keep a copy of the certificate available. We created, with the help of the advisory committee members, both the hospitals and the farmers and producers, a document that we're hoping is going to be really helpful. It's called Using Written Protocols to Guide Direct Procurement of Food from Farmers and Sustainable Farmers and Producers. And so we sort of outlined why we believe hospitals should consider having a protocol, and how to develop that protocol, and why, if they include certain things in it, they might end up excluding certain farmers from the market, and sort of, encouraging them towards the baseline that more farmers are going to be able to meet. But in doing that, they would, helping to make that whole process clearer for the farmer, so you have a clear understanding of, what it is that they need, and also to be, make sure you have good communication, which relates to this proactive and education and marketing to hospitals. Help them to understand what it is that you're doing to address food safety in your operations, and where your items are processed, so it's not a mystery to them, that they can see that you've got a USDA inspected sticker or whatever, or state inspected sticker, that's just like maybe what they would be getting from their suppliers. And we have more also in the reports about, what are some low prep and food prep neutral items that might be more easily incorporated into a hospital's menu with little or no additional labor or equipment. And so those are some places you might want to focus to start with in your conversations with them. We encourage you to try to work with hospitals on pricing. They are very focused on pricing, but also encourage you not to sell your product below cost, even for a short period of time, that it's more important to help hospitals understand the value behind your product, and help them to look for ways to increase efficiencies, or you would increase efficiencies that can then decrease delivery or other hard costs. And we created this for hospitals, this financial strategies for incorporating sustainable food into a hospital's budget, but farmers should be familiar with them, so that if the hospital you're meeting with isn't, and maybe you can make some suggestions. And it just helps you to understand more about what are the kinds of things they could potentially do if what you're selling them is going to cost them more than what they would be getting from somewhere else of a similar product. Also, we're getting close to the end. Remember that word of mouth is really powerful. Hospital food service employees talk to each other, so that's a benefit, and that if you can develop positive relationships with these one or more hospitals, then that can help you to start to build that relationship. And so always be keeping that in mind as you're working to initiate and carry on your business with the institutional customer as well as a hospital. And to help in that, we created a document called 10 Steps to Creating Mutually Beneficial Relationships with Local Sustainable Farmers and Producers. So longer term, basically, we encourage you to if you're in an area where you're working on aggregation or developing food hubs or other, aggregation distribution models, to try to engage any hospitals in your area that might be interested and get them involved in that process. So here's that online resources for sustainable farmers. I might have done that twice. And this is a pretty picture of the report. This is the website, if you haven't already been to it, iatp.org/farm-to-hospital has all of the information we talked about there for you to look at or download. So I'm going to turn this back over to Anna.
Thank you, Marie. A great overview, and I'll have you keep the controls of the presentation, but I will take that go to facilitation. There was a lot to cover, and for those of you who maybe also saw it, Catherine, our organizer, just added that same link to our website in the chat log for everyone to see and to copy for a later time. But now I think, and we have a couple questions that came up, but I really think it'd be great to ask, because I think our next presenters will be able to respond in addition to Marie to a few of these questions. And I want to give Jennifer and Jean and John, 3 of our advisory committee members, the chance to speak for a bit. I think this is a great time, especially since this is our farmer-specific webinar, to be able to ask them some, any questions you have. So start sending them in as they come about. But what I will do right now is I'll hand it over to them and just say a few things. Hudson Hospitals and Clinics, as you're now aware, was one of our 3 hospitals participating in this project. And they were one of the hospitals that had already started to explore this and were purchasing some produce from a local farmer, Threshing Table Farm, which was Jody Lenz, who was also on our committee. Jody's not with us today, but John Peterson is. John is another producer in Minnesota who has sold into institutional markets, and now just recently is also now selling into Hudson Hospital and clinics. So I want to thank them in advance. They've been a great part of this process and giving us a lot of input and really vibrant discussions, and I feel fortunate that we have them here to share in that discussion with you. So Marie, if you want to click to the next slide, and if Catherine, if you can, if they're muted, make sure Jean and Jennifer and John have access to speak, and I'd like to introduce Jennifer and Jean and have them. Jennifer and Jean, if you want to speak, just start out by giving us telling a little bit about your history at Hudson Hospital and your experience in buying from producers and farmers.
Thank you, Anna. This is Jean, and Jennifer is with me also. And our experience, I think to start off with, the hospital itself, Hudson Hospital, is very interested in sustainability. We have a green team. And some years ago, we did sign the Healthy Food and Healthcare Pledge. And as part of that pledge, initially we had employees who bought shares in a CSA farm. And we were wondering, how could we begin purchasing from that farm as part of our sustainability efforts? So I initially asked our county sanitarian, are we able to purchase from this farm? And she said, I think that's a great idea. You need to talk to the state of Wisconsin. So I contacted the state of Wisconsin and said, how can I go about this? And they sent me some guidelines for good agricultural practices and suggested that I tour the farm and develop a checklist. So from there, not being a person who grew up on a farm or knowing that much about farming, I asked Jennifer, whose family did raise steers, and another employee, Colleen, whose family raised swine, if they would go with me to do this inspection. So we went to the Threshing Table Farm, met with Jody and her husband Mike. We did a tour of the farm, and we went through this checklist that had been developed by the state and reviewed it with them, and they met those items on the checklist. So then we set up a plan to purchase from them. And really, it has been a great experience for us to purchase from Jody. Another thing that happened along the way, since the hospital was interested in sustainability, there were some articles in our local newspaper about these efforts. And as a result of that, I had two young people from the 4-H contact me and say, could we meet with you? And I thought, sure, that sounds fine. I'll meet with some kids from the 4-H. And they asked me if the hospital would considering going to the St. Croix County Fair and perhaps purchasing a 4-H animal. So the first year that we did that, I again asked Jennifer's dad if he would go with me, and also Colleen, since they knew about farm animals, to help me select a hog the first year. So that's how the hospital was able to do some local purchasing. We were able to have that processed at a USDA local processor, and the next year we were able to purchase a steer. So that's how we started making some local purchasing work. And then working with IATP really gave us the opportunity to begin meeting more farmers. So we got to tour John's Ferndale farm at his turkeys, and we were able to start purchasing turkey from John. And I thought maybe I would have Jennifer tell you a little bit about the employees in our department and how they have worked with the local products, and also about how our relationship with Jody and her farm has gone. So Jennifer, if you'd like to go ahead.
First of all, when we started with getting produce from the farm, it worked out really well because on Wednesday they would send me a list of items that they thought would be available for Monday delivery. And then I would take a look at the menu, put together the order on Friday, send it off to the farm, and then that produce was picked on Sunday and delivered Monday morning. So we knew we were getting very fresh produce from our CSA farm. And the employees started to get very excited about it because they, as soon as the boxes would come into the kitchen, they would be at the boxes trying to find out what was new, and also what we were going to menu to use some of these new products that we were getting in. So we had a lot of fun with that. We also advertise in our cafe when we have threshing table produce, which opens up some communication with our cafe customers as far as a threshing table and locally grown produce. So that was also exciting for us. And as far as the turkey products that we purchased, we had a holiday party that ended up to be kind of a harvest theme, and we thought the turkey loins from the Ferndale market would be perfect for that. And that was one of our best received holiday meals that we've ever done. And it was very simple, yet it worked out very well for us, and people really enjoyed that product. We also, at the same time, purchased some ground turkey, which we made into taco meat, and people really enjoyed that. We sold out of it, so that wasn't an issue to have turkey versus beef. It actually worked out very well. So I think that the relationships that we've built with the farmers has been beneficial to both the hospital and to the farmers.
Thanks, Jean and Jennifer. I have a couple questions that will be pertinent to this, but let's quick let John introduce himself because I think it'll be great to get both perspectives on a few questions. Marie, can you advance the slide? Thank you. John Peterson is the third generation of his family to grow turkeys on his family farm in Cannon Falls, which Jennifer mentioned, and Jean and their new relationship. John, you do an excellent job of introducing your farm, and so I'm going to hand it over to you.
Well, thanks, Anna. Glad to be here. I'll just give a quick intro and a little bit of background on our farm, and just share a couple of thoughts on what we've been doing with food and health care. So like Anna mentioned, my name is John Peterson, and I'm here on behalf of my family's turkey farm in Cannon Falls, Minnesota. And for those of you that aren't from this area of Minnesota, Cannon Falls is sort of smack dab between the Twin Cities and Rochester, about 45 minutes each way. So we have some nice distribution advantages being so close in geography to both of those metro areas. Our farm was started in 1939 by my grandparents, Fern and Dale Peterson. So that's where our name comes from, Ferndale Market, as a way to honor them. And I oftentimes say we still grow our turkeys very much the same way that they did, so it's very fitting to have their name on the package of all the products that go out our door. You can see the picture that Anna has up on the computer. We still grow all of our turkeys free range. During the summertime, we move them onto fresh grass each and every week. We never use any antibiotics, any growth promotants of any kind, and we do have USDA approval to make both of those label claims. My wife and I actually returned to our farm in 2008, and that's the time at which we began direct selling our finished turkey products. And today we sell to about 100 different accounts, and amazingly we're pretty well balanced between retailers and food service accounts. The retailers would tend to be natural food grocers, and our food service is a pretty good mix of colleges, corporate settings, and amazingly a pretty strong K-12 school business as well with the growing farm-to-school movement that we've seen here in Minnesota. We do, let's see, most of our distribution on our own. We run a route to the Twin Cities Metro and also to Rochester, but we do work with a couple of independent mom-and-pop type distributors as well to broaden our reach and get product out a little bit further. I always mention, most people tend to think of turkeys just as the whole bird that we see on the Thanksgiving table, but the bulk of what we sell over the 12 months of the year is actually further cut or processed. And we run a total of about 20 to 25 different items, everything from ground turkey that Jean and Jennifer mentioned, to turkey tenderloins, sausages, turkey burger patties, and then of course all the individual meat cuts. couple things just in regard to the healthcare business that we've done. We have sold to 3 different hospitals in the past, including Hudson, of course, that you've heard about. And one of those 3, St. Mary's in Duluth, which is an Essentia hospital, is serving our turkey as a part of their regular menu. And I believe I'm correct on these numbers, that they have made a pledge to source 20% of their food locally by, I think it's 2015. And so they've been a good and continuous supporter. And for those of you that are farmers, you know that's what it takes, is people who do things on a continuing basis to make it sustainable. So that's been great, and we're appreciative of all of the hospitals that we've had a chance to sell into. And a couple other things from a farm standpoint, I know we have an advantage being poultry or meat producers, that we have a product available 12 months a year. I know oftentimes when we talk about local food, people think about the seasonality and maybe then the difficulty of doing things 12 months a year. But as meat producers, we can sell frozen meat 12 months a year, so that gives us an advantage. And the second advantage that I think we have is that we do all of our processing at a USDA facility, and even all of our secondary processing for grinding and sausage making is all also done at USDA facilities. So we're able to sell our turkey into healthcare and food service settings without having further regulations, and that's probably good for people on both sides of the table to hear, both farmers and purchasers, that any meat product coming out of a USDA facility can certainly be sourced and served anywhere across the country. So I think I'll leave it there and see what questions folks have.
Thank you, John. I think a good segue from that, John, and actually for Jean, Jennifer, John, all of you to maybe respond. And I think this is always a topic that comes up quickly. And the question is, how do you address food safety issues for small farms? And that would be answered in different ways. But Jean and Jennifer, do you want to start just by maybe, you touched on it, but what your protocol is for meeting the needs with Hudson Hospital's food safety issues?
Hi, this is Jean. The protocols that we followed were strictly from the state. And we realized that we must use that checklist and tour the farm before we go ahead and make purchases from them. And a few examples of what might be on that checklist. If they also have animals on the farm, such as chickens or goats, that those animals can't be out in the field where the crops are growing. Another example would be, do they have a protocol for what happens if a farm employee is sick? What are they allowed to do? So those would be a couple examples of protocols that we followed for safety. And we treat the produce in the same way that we would treat the produce from any other vendor, that we have certain guidelines that we follow for cleaning the vegetables that come in or cleaning the fruit that come in. So there's no difference in those protocols. What the state gave us as another guideline, that there's really a low level of processing, that a small farm can wash the produce and can cut the tops off things like carrots, but that is how much processing can be done. Jennifer, anything to add?
No, I don't.
Okay.
Thanks, Jean. And John, maybe you can just, since you sell into variable different markets, touch on sort of the difference you see with your buyers on their food safety issues, and the sort of gamut they've run.
Yeah, well, like I mentioned, a lot of our food safety concerns are addressed, fortunately, by our processing partner, because they're a USDA facility. They have to have, HACCP plans and all of those things, plenty of third-party audits, and we certainly have customer requests for that information and can provide any of that. But from our own standpoint more directly, we are inspected by the state of Minnesota for all of our refrigeration, both our freezers here where we store frozen inventory, and then also our delivery truck, refrigerated delivery truck. So, we do have to maintain all of those and do go through an annual inspection. And customers will oftentimes ask to see that as well, to make sure that if they're purchasing frozen ground turkey, that we're not transporting it down the road at 60 degrees. But primarily for us, that all of those concerns would be handled through our processor.
Thanks, John. Jean and Jennifer, can you? I know this question didn't come up here, but it comes up often. Can you explain how you pay, sort of the transaction process of buying local produce and any of just those day-to-day logistics? Maybe walk through how often you order and that sequence.
Sure. For the threshing table, I order once a week that's delivered on Mondays. That's what I would consider my large order. Occasionally, because the threshing table sends out a newsletter to the CSA members, and it'll tell what's coming up in their upcoming boxes, I'm able to kind of tag along on that, and if I see something that I'm short on and I'm not going to make until my next Monday delivery, I'll send an email off to the farm and ask if I can get onions or carrots or whatever the item is. If they have extra that are going to be in the CSA boxes, if they have extra, if I can get that in. And if they're able to, they will drop that off at the same time. So that's just a small add-on order that I get on Thursdays when they deliver the CSA boxes. As far as the threshing table and payment, because we do get weekly deliveries from them, I have set them up as a vendor in our accounting system, and I just send off their invoices and they're paid directly from Health Partners. With John and the turkey farm, what we did was we set up, after the delivery came in, I actually talked to him and we used my corporate credit card to pay out that invoice. So that's the way we set up payment for them.
Thank you, Jennifer. And John, a question that came up. I know you, with your experience in this, and you've heard and aware of some of the myths about getting into the market, into the hospital market. Are there any myths that you would like to, sort of debunk about selling or buying into this market, or anything that you've come across to notice that is very different than selling into farm-to-school market?
Yeah, that's a great question. I mean, I think in regard to myths, the first myth that probably isn't unique to healthcare, but that all of us as farmers are told so often, is that there's going to be a cost problem, and that right away we need to figure out how to either lower our cost, or that's not going to be a fit right out of the gate. But we've seen, particularly in a lot of our colleges that we sell to, chefs that want to make it work and find some pretty interesting solutions, and maybe look beyond the initial cost and go further and look at value. One example for us is that our turkey doesn't have any added water or sodium like most conventional poultry does. And so even if we are slightly higher right out of the chute, by the time a chef or operator looks at the yield and the finished cost, we're oftentimes right in the wheelhouse. We've also seen a lot of that with chefs, and Jennifer alluded to this, subbing ground turkey for ground beef. I know beef farmers don't like to hear me say that, but that's a good way to find some cost savings and be able to make some local foods fit. So I think that's that's always a myth that we battle, and we need to keep making headway on that. And in terms of differences between the other customers that we've sold to in the food service world, I'd say the only difference that I've seen pretty strikingly is that in the colleges that we work with, they have a customer base that's every day asking where that meat comes from. College students that, as they walk through the line, want to know where the food is coming from, and so they are really the drivers of that change. And I don't sense that in a hospital setting they maybe have the customers that are as proactive in making that request. And so, like Jean and Jennifer said, the hospital needs to take some of that initiative to really tell the story, because I think it's certainly going to be appreciated by the staff and patients, but maybe the impetus isn't driven so much by the customer.
Thank you, John. Actually, it's a great segue for Jean and Jennifer to maybe add in. I know I've heard you speak a bit more. You mentioned that you get a response. Your holiday menu, for example, that had a great response. Can you speak a bit more about how the menus have evolved? And as John alluded to, it might not be coming directly from the patient or your staff, but what the response has been as far as noticing and sensing a difference and paying attention to the menu changes, specifically the local product. And before I hand that over to you, Marie, if I could just ask you to advance the slide one more. I think we have one more slide. So, Jean and Jennifer.
Anna, I will mention our patient response to that. When the clinical dietitians will go and visit the patients and they let them know that this is local produce that's on our menu, or the hospital bought a hog, or the hospital bought a steer, and that's what's on your menu, patients are just amazed that they're actually able to get that food in a hospital. So I think, as John already mentioned, it's a step that people are more interested in. Where does my food come from? We notice in the summertime when we have all of these different types of greens on our salad bar and tomatoes and cucumbers, we have people ask us, so what kind of spinach is that today? Did that come from the threshing table? So I think it's just beginning in the healthcare setting, and I agree with John, it probably is college student driven, that there's more interest there, but I think the movement is spreading. Jennifer, anything to add?
Not really.
Not really?
Covered
okay.
everything.
Great, and that fits in. Some of our audience members are chatting in and reminding us too that it's not just the staff or the patients, but the family that are there eating at the cafeteria that are visiting people, and how you tap into that. Jean and Jennifer, if you can also address, we have a great question from an audience member about if you have any experience, the hospitals coordinating, and John, maybe you as well, but coordination between the hospitals and subsidized farmers markets for their low-income patients. And this relates to writing prescriptions for fruits and veggies and covering the costs for high-risk patients. Either of you have any experience or involvement in this?
This is Jean. I would say our experience is maybe more indirect. We do have a community garden on site, and we have some master gardener volunteers who each year have some donation gardens. So their plots, I think this year they had 4 10 by 20 plots, and they used what was grown in those gardens to donate to the food shelf. So that's how the hospital has gone about it. We also have a relationship with some people in the community who, when we have certain things, like sandwiches that we make today so we can't sell tomorrow, they will come and pick those up and distribute them to some needy people. So that's how that relationship has worked for us.
Thank you. John, have you come across any or know of any other producers, or you yourself selling into any of your hospitals for any of the same need where they're prescribing it to the patient?
That's a good question. I'm actually not aware of anything like that myself, no.
A question, and this is different based on, John, you're a livestock producer, and it might not vary as much as some other products, but can you weigh in, and then Jean and Jennifer weigh in when you buy from Threshing Table, about how much does pricing for your products or the products you're buying fluctuate during the year?
Yeah, Anna's exactly right. Our pricing is actually consistent throughout the year, and we've done that very intentionally to try to move people away from a commodity pricing mindset and really help them shift to a real cost of production or fair market price. And obviously our costs fluctuate some throughout the year, but we have a pretty good handle on what it takes to grow a turkey and produce the different cuts. So we actually have the opposite approach of really trying to maintain consistent pricing 12 months a year for our customers.
This is Jean. I just looked at our purchases from the threshing table compared to the other vendors we purchased from, and the threshing table prices did not vary. Comparing that to a large vendor, their prices do vary, even over the season. I simply looked at the months of July until November because that's when we were able to purchase from threshing table. And in doing that analysis, I noticed that at times the threshing table prices may have been lower than our vendor. At times they were higher, at times they were lower. So not much fluctuation from threshing table, but from the larger vendor, yes.
Thank you. We're getting close to time. I think at this point, Marie, if you could advance to the last slide, and I'd like to give Jean, Jennifer, and John, as well as Marie, a few last words. We just have a couple minutes total, so if there's anything, especially Jean and Jennifer and John, with your experience that you'd like to share with our audience, primarily farmers, about this market. I'll start with you, and then Marie, any closing comments I'll follow. John, anything that you would like to share in closing?
Yeah, one quick thing that I thought of that I guess I didn't mention in my opening piece is that distribution seems like such a key challenge, whether we're dealing with healthcare or any of the other food service accounts that we deal with. And I say that because whether we like to think about it or not, we're probably competing with the Cisco's and the big distributors of the world. So I've sometimes joked, and Anna's maybe heard me joke about this before, that we really run a distribution company, and on the side we have to figure out how to grow turkeys. And there are days that it feels like that's the case. We know that we need to be consistent in the days that we deliver. We need to have do our best to have consistent availability. Obviously, we're not at the scale where we can always do that, but we really need to make sure that our customers can rely on us to take their order the same way every time, to bring their order the same way every time, ideally to be there, about the same time, the same day every week. All of those things that really replicate the model that they're accustomed to presently, because we are asking them to make a little extra effort to source from one or multiple additional vendors. So I think we need to be as efficient and streamlined as we can be. And the only other thing I'd say, just as words of hope, that we have seen such tremendous growth in Minnesota in farm to school, and I'm amazed constantly by the schools that are interested in sourcing a local antibiotic-free turkey. And to my mind, if it can be done in schools, it can certainly be done in healthcare. So I think that's a lot of reason to be optimistic that change is on the horizon.
Thank you, John. That's great to hear. And Jean and Jennifer, I'll open it to you, but I'll also say, Jean, if you could just quickly also speak to delivery charges as it relates to what John mentioned is important. And I want to make one comment. There was a question about if there's a minimum quantity requirement for selling into hospitals. And I think Jean and Jennifer's example is that no, because they started at a very small level. Jean and Jennifer, I'll let you say a final comment about that in the project.
Thank you. John, I think you said it very well, that if schools can do it, hospitals can do it. Delivery charges from our large vendors, of course, you have to have a minimum order, or you will have charges on that. From threshing table,
we don't have a minimum order, but we do have a $10 delivery charge when I get the large order on Monday. When I have the small order that comes in when they deliver the CSA boxes, there is no delivery charge that's associated with that small delivery. I think part of our job in food service at the hospital is to get our employees excited about buying from the threshing table. That's really, they're kind of the key. They're the promoter out on in the cafeteria. The dietitians are the promoters of the threshing table food when they see patients. And so part of my job is to get people excited about what's coming in off the truck. And there is some extra labor involved in cleaning that produce, because so much of what we buy from our broadline is already processed. It's already cut into florets, or it's already peeled and chopped and ready to go. So that's part of the challenge, but our employees are excited. So it's really not, it doesn't hold us back from purchasing anything, with the exception of beets. The cook won't let me buy fresh beets anymore.
Thank you, Jennifer and Jean. Thank you, John. We are getting right here at the end of our time. We actually are there. Marie, if I could ask you to just advance the slide to the, should be one more slide that should have contact information on it for both Marie and I. I want to say thank you to everyone for being on the call. I specifically also would like to say thank you to NCR SARE, as they really do fund cutting-edge projects every year through grant programs like this. And they've awarded over $40 million worth of competitive grants to farmers and ranchers and researchers, students, educators, the public and private institutions. And we're grateful to be able to tap into this project through them. Even more grateful for our producers and our hospital participants in this project, and for all of you who are interested and continue to push on this market to support and provide a place for local sustainable farmers to have a viable market. And I will hand it over to Marie to give one last couple words of wisdom. Marie, go ahead. Sorry, Marie, are you there? You might be muted if you are talking.
Sorry for the further delay. So all I really want to say is that, you know, if and when you're doing your outreach and you're meeting with potential hospital clients and you get discouraged, I encourage you to keep Jean and Jennifer and John and all of the other folks that are like them around the country in mind, and just know that it's possible. And you won't get in the door at every hospital, but you can get in the door at some hospitals, and that's what I would really stay focused on, and what are the benefits of that happening for all the folks that work at those places and are treated in those facilities.
Thank you, Marie, and thanks for everything on this project. And there was one last comment. We didn't get to everyone's questions, and I'm sorry. One question that was frequent, we have recorded this, and that will include the slides and the audio. That'll be available on IATP's website, on our YouTube page as well, and you can follow. There'll be links to that from the one link you have that is our Farm to Hospital page. And last comment is we do have one more webinar on Thursday that is a hospital-specific focus. You can find links to that through that same host main page. And if you have local hospitals and members in your community that work within the hospitals, please forward that to them. This gets the discussion going. That will be focused on hospitals and what they need to know about the farmers' supply side and issues. So thank you, everyone, for your time. Thanks for participating in this, and we hope we can continue this discussion and continue to work towards getting sustainable farmers and produce into the healthcare system. Thank you.